Okay. All right. So a couple things before we get started. Hopefully everybody realizes our exam is coming up on Monday. So you have a practice exam up for that. So this morning, I also added a document of some additional kind of study guide-ish questions. They're optional to do, but there's a link in there. If you click on them, it's kind of like essay-like prompt questions. As you scroll all the way to the bottom, there's a key linked with my sample answers for you if you choose to study that way, either in written form or talking out loud or using that to prompt drawings and whiteboards and that kind of thing. You should also see a quiz for Monday. Can somebody give me a thumbs up, thumbs down? Is that visible? It's visible now? Okay, thank you so much. Okay, so here's the deal on that and the deal on content that we're covering for today. So we're gonna go through all this partial pressure stuff will be on the exam. Hopefully we'll be getting to hemoglobin saturation and dissociation curves and stuff by the end of class. That won't be on the exam. So the transport of gases packet won't be on the exam, but there will be a couple questions on the quiz about that. The reasoning for that is can take you a little bit of time to wrap your mind around those dissociation curves. So I want to give you time to focus on that for the future. While it's present, I'm going to ask you a couple of questions, but I think you have enough to study for the exam without that additional kind of chunky topic on there. Questions about that? Okay, cool. All right. So when we left off, we were thinking about the oxygen cascade and we were thinking about partial pressures. So we learned that when we have partial pressures, what we're talking about is the fact that if you have a mixed gas, all the pressure of that gas is due to a bunch of individual components kind of adding up together. So we can take a percentage of a pressure and describe that as the partial pressure of any given molecule, any given gas. We know that these partial pressures are also related to the amount of gas that you have dissolving in solution. So for our purposes, into the bloodstream. There's a little bit of fiddling in there. It's not directly a concentration because different gases have different solubilities, carbon dioxide having higher solubility. But we can also describe the amount of gas in the bloodstream as a partial pressure, because as that blood passes past the alveoli, you've got gas at a specific partial pressure in the alveolus. You've got the bloodstream coming along. And the blood is moving slow enough that the partial pressures will come to equilibrium. So equilibrium, we're thinking equal. So whatever that partial pressure of oxygen is in the alveolus, our partial pressure in the capillaries passing by is going to come to equal that same number. We happen to know that's 100 for oxygen when we're thinking about our lungs. Same thing is happening with carbon dioxide. So we can trace these partial pressures, which are essentially measures of the oxygen and carbon dioxide content of the blood through the bloodstream. So we can trace, let's say, from the right side of the heart, that's going to be our deoxygenated blood full of carbon dioxide. We're going to go to the lungs. We're going to get rid of carbon dioxide and we're going to fill up with oxygen. And we're going to come back to the left side of the heart. We're going to see that blood flow out to the systemic arteries with its high oxygen content, partial pressure of 100 millimeters of mercury, and its lower partial pressure of carbon dioxide, partial pressure of 40 millimeters of mercury for carbon dioxide until we get to tissue. Our respiring tissue, it's active, it's making ATP, which means it's using oxygen, giving off carbon dioxide. So that's when we see our shift. So as we're passing by tissue, we see, again, these partial pressures coming to equilibrium, this time with those cells that it's passing by in these systemic capillaries. So this is when we see our partial pressure of oxygen drop down to 40, and we see our partial pressure of carbon dioxide bump up a little bit up to 46 as we're adding that carbon dioxide as our byproduct of metabolism into the blood. and using that oxygen to fuel ATP production. So all that stays the same. Come back to the right side of the heart, go through the right side of the heart, doesn't change until we get back to the lungs. That's what we were doing. So the diffusion between the alveoli and the blood in the lungs is rapid because we have this small barrier for diffusion, just those type 1 alveolar cells and the endothelial cells lining the capillary. They're glued together with a basement membrane. We've got a large surface area. That's why we have these grape-like clusters of alveoli. That's why we have so much splitting into all these branching networks of capillaries surrounding them. So we left off looking at these last two figures. Last time looking at the length of the capillary versus our partial pressures of our gases, right? So what we're looking at here, right, we're looking at when our blood is first coming to our capillaries that are entering the lungs, we're thinking about oxygen. Okay. So when we first get to the lungs from the right side of the heart, right? So we went out through our pulmonary trunk into those pulmonary arteries, right? We had our partial pressure pretty low for oxygen. But by the time we get through about a third of the capillary, it doesn't take at all long for us to come to equilibrium with the partial pressure of oxygen in the alveolar air. So that is how we're popping up to 100 as we pass by the alveoli, as we come to equilibrium. And so that's the oxygenated blood we're carrying in the pulmonary veins. Because remember, vein and artery are about direction, right? So this is the one time we see oxygenated veins coming back specifically to the left side of the heart and then getting pumped out to systemic circulation. The same sort of thing is happening with carbon dioxide, but it's in the reverse, right? So our mixed venous carbon dioxide, right? So what we're talking about is all the blood coming back to the right side of the heart through the superior vena cava, the inferior vena cava, and that right atrium, it gets mixed together, right? So this is why we're saying mixed venous blood, right? So as we come from the right side of the heart through those pulmonary arteries, okay, we've got a partial pressure of carbon dioxide of 46. So that's our high level for carbon dioxide. But by the time we're ready to come back to the heart, to the left side of the heart, to go back to circulation, we've dropped back down to our lower value for carbon dioxide is 40. Okay. And we've actually got some wiggle room here. We've got extra time because we usually come to equilibrium in that first third of the capillary again. Okay. So we've got slow blood moving through lots of capillaries. And even if your blood speeds up, you actually have a bunch of the length of the capillary that didn't have to do gas exchange, but under changing conditions would still be able to. Okay. So what we're thinking about with all of this, right, is essentially diffusion, right? So everything is working down gradients. When we're talking about partial pressures, we're talking about partial pressure gradients. So really, we're just talking about oxygen's moving from wherever there's a high partial pressure of oxygen to wherever there's a low partial pressure of oxygen. And when we come to equilibrium, we're saying we made those two numbers equal. Okay. So for oxygen, we're paying attention to our partial pressure of oxygen in our respiring cells. So at the tissue level, so like, say you've been using your quads, your muscles a lot, right? Those cells have used up a lot of the oxygen that was in them normally, right? So they have dropped down low to about 40 millimeters of mercury as our kind of benchmark, might be even lower, right? Because our arteries, our systemic arteries are coming in fully oxygenated with that partial pressure of oxygen at 100. As we pass by that tissue, and if we have oxygen at 100 in the blood, oxygen at 40 in the tissue, we're going to have movement. So we're going to go from high in the blood, that 100 number, towards the tissue with that low of 40 until in those capillaries we come to equilibrium, right? So that diffusion, it's passive transport, just moving down a gradient. We don't need any helpers. This is just simple diffusion because we can get across cell membranes because we're a nonpolar gas. Okay? So we are going to come to equilibrium with that partial pressure of oxygen that we saw in the tissue, so that lower number, which is why as we return to the heart, we see that the partial pressure of oxygen in those systemic veins is now at 40, just like in that tissue that we passed. Carbon dioxide is working the same. So if you're tracking partial pressures of oxygen, you only pay attention to the partial pressures of oxygen. If you're paying attention to carbon dioxide, just pay attention to the partial pressure of carbon dioxide. Okay, so we have other benchmark values. So for carbon dioxide, our high number is 46, our low number is 40 as well, but they're going to be in different places. Okay. So the cells that are doing metabolism, the respiring tissue, so like your quads, right? As they were using up that oxygen, they were making excess carbon dioxide. That's where the carbons in the glucose molecule go, right? Like we rip them off during metabolism and they turn into carbon dioxide. Right, so now they're sitting around in that tissue that you've been using. So this is putting our partial pressure of carbon dioxide in those cells in the respiring tissue at about 46. As we were coming along with our systemic arteries with their blood, they have our lower value of carbon dioxide in them, right? So they were down at 40, but they're coming through the capillaries going by, let's say your quads, right? Now we've got 40 in the blood, 46 in the tissue. So diffusion happens until we reach equilibrium, right? So that extra carbon dioxide, that excess with the 46, that high number is moving towards the blood where we have that concentration, sorry, the partial pressure of 40 millimeters of mercury, that lower number, until they're equal. They equal each other when they're both 46, which is why as those systemic veins return to the heart, our partial pressure of carbon dioxide is 46 until we get back to the lungs after being pumped through the whole right side of the heart. Questions about this process? Okay. There are a lot of words, but only 3 numbers you actually have to remember, 100, 46, and 40. You just have to remember where it makes sense for those pressures to exist. Okay. So this means that when we're talking about mixed venous blood, so the mixed blood returning to the heart, right, our amount of oxygen and our amount of carbon dioxide, it's going to be exchanged ideally at the rate that any tissue is using that gas, right? So we want to be delivering as much oxygen as that tissue is using. We want to be taking away as much carbon dioxide as that tissue is creating, right? And we know that we have mechanisms for this to work out better, right? Like, so when we were talking about arterioles and capillaries last time, we know that oxygen and CO2 concentrations, if they get off kilter, change the size of our arterioles and therefore change the basically rate of blood flow to any given vascular bed, right? So we are able to kind of match this up ideally. Okay. But if you were to measure the partial pressure of oxygen or carbon dioxide in some like random vein, right, it might be a little different depending on what tissue it passed by, how active that tissue was. So that's why we use this mixed venous number for when everything's getting mixed together as it returns to the heart. Lets us get a nice, easy, average kind of benchmark that tends to be true. Okay. So the blood in the pulmonary arteries that are leaving the right side of the heart, going to the lungs, ready to pick up more oxygen, deliver more carbon dioxide. That's where we picked these benchmark numbers of our low oxygen level being at about a partial pressure of 40, our higher carbon dioxide level being at about a partial pressure of 46. Okay. So when we think about what determines the alveolar partial pressures, like in the lungs, we're coming to equilibrium with the partial pressures of oxygen and carbon dioxide in the alveolar air, right? So it does matter what exactly is in those alveoli. And we've really talked about this already, right? When we started out talking about it, we weren't specifically measuring partial pressure numbers, but conceptually we've spoken about this already, right? So it's going to matter how much oxygen or carbon dioxide is in the fresh air you breathe in So the partial pressure of O2 and CO2 in the inspired air, so that's your fresh air. It's going to matter how fast you're breathing, right? If you're breathing faster, you're bringing in oxygen more often and you're breathing out more often. So you're putting out carbon dioxide more often. So that's going to make a difference. So that's why our minute alveolar ventilation is on here, because that takes in a little bit of that respiration rate, that respiratory rate in there. Okay. We'd also want to think about how active are you, right? Are you using a lot of oxygen? Are you making a lot of carbon dioxide right now or not? Right, so that's where the respiring tissues come in. But particularly, we want to remember that more than just minute alveolar ventilation, which was just your tidal volume, so your easy breaths, times your respiratory rate. Right? The alveolar ventilation in particular is going to make a difference. So subtracting away that dead space volume so that we're getting just our amount of fresh, new air, right? So the dead space volume that is included in the minute alveolar ventilation number, but not in the alveolar ventilation, right? We subtracted away for alveolar ventilation. And that old dead air is going to contain a lot of carbon dioxide. It's going to contain less oxygen. So you've messed with those partial pressures in there. Right, so the alveolar ventilation rate is really helpful and important for us here. So we have some words for breathing changes. Actually, there are a lot more words than this if you're trying to describe breathing changes, but we're going to focus on just these three. Okay. So when you are moving your body and you're using more oxygen, producing more carbon dioxide, your breathing rate should change, right? Your body tries to adjust to this. So when you're breathing fast, but it's because you need a lot of energy because you're doing stuff, that's not so much a problem, but we do have a word for it. So hyperpnea means that we are increasing our ventilation rate, right? So breathing in and out more quickly. But it's because we have more of a demand for oxygen because we're producing more carbon dioxide. So this change in breathing shouldn't make a huge change on the partial pressures of the gases in your arteries because we've adjusted really to try to match demand. Okay. Hypoventilation and hyperventilation both are going to make a difference for your partial pressures of gases in your arteries in particular, we'll think about, but both of them. So in hypoventilation and hyperventilation means you've changed your breathing rate, and it's not because you're just trying to equal the demand for oxygen and the demand for breathing out carbon dioxide. This is for some other reason, like maybe you're having a panic attack or maybe you've taken some type of depressant and it's making you breathe really slow unnaturally, right? That's when we would use these words. So hypoventilation, hypo means low. So hypoventilation is that you're breathing too slowly. Okay. So our ventilation, our movement of air, is not meeting the demands of our body if we're hypoventilated. Okay. So your body is still working. You're still using oxygen, still pumping blood around, but you're not breathing as often as you should be, right? So now we're going to see that our partial pressure of oxygen in the arteries that are swimming around, it's going down because we're not breathing in fresh air often enough. So when we think about that difference between minute ventilation and alveolar ventilation, right, we're mixing in like too much dead air, right, when we look at the length of time, right? So this means our partial pressure of oxygen in the arteries goes down. And it means not only are we not breathing in often enough, not bringing in enough oxygen, we're not getting rid of our carbon dioxide as often as we should. And too much carbon dioxide is actually the kind of bigger emergency for your body. So it's really important to notice that in this situation where you're not breathing fast enough, we're having a buildup of carbon dioxide in the blood. So you're not breathing it all out 11 times a minute or something. Maybe you're only taking 3 breaths a minute, right? So now all that excess carbon dioxide is building up, right? Because it should be coming out every breath, but now it has relatively less time to come through equilibrium. So some of it is kind of spilling over into the arteries, raising those partial pressures of carbon dioxide throughout the system. So we see higher levels of carbon dioxide than we should, even in our arterial blood. So that's a problem. So is hyperventilation, okay? But hyperventilation, you'll notice you get a bit woozy, but you're more likely to like collapse if you're hypoventilating, not breathing enough, than if you're hyperventilating. So in hyperventilating, you're breathing too fast, right? So you're having a panic attack or something. So this means you're breathing in lots of extra fresh air. So we're seeing our partial pressure of oxygen in the arteries go up because you're breathing in lots and lots of fresh air all the time. And you are seeing that arterial partial pressure of carbon dioxide go down, right? So you're breathing out really fast too, right? So you're getting rid of carbon dioxide faster than you usually would, right? And so because we regulate carbon dioxide and oxygen levels, you can feel this, okay? All right. So both of these shift our partial pressures of the gases. And if you took a blood draw, you would see those changes. Here are some more words related to changes in breathing and changes in gas levels in your blood. Don't expect you to memorize these, but you can see that there are a bunch of them, mainly focused on whether you are breathing, whether you're ventilating, and then also what's happening with the blood, right? What's happening with the amount of oxygen in the blood or in the tissues, what's happening with the amount of carbon dioxide in blood and in the tissues. Okay. So for the exam, that's about where our content will end. But we are going to keep moving so that we don't get further and further behind and have to be busting our butts during finals week to try to get through our content. Okay. So we're going to talk about the transport of these gases in the blood now. Okay. So in your blood, most of the oxygen is moving bound to hemoglobin. Okay. So we talked about hemoglobin before. We know that hemoglobin is in your erythrocytes, so in those red blood cells. We know it's made up of those 4 subunits. So it has the globin part, which is the twisty part of the protein, has the heme part, which is that ring containing iron. That's where our oxygen binds. And we were talking last unit about how we recycle that iron, recycle that heme part of the hemoglobin. Okay. So hemoglobin is particularly important for oxygen because it's not very soluble in liquid, right? It's not soluble in the plasma, right? We mentioned when we were talking about partial pressures of gases versus liquids that solubility makes a difference, right? And particularly that carbon dioxide is more soluble in the blood. That's true. And since oxygen isn't very soluble, but we do want lots of oxygen, we're going to do this nifty thing where we bind it to hemoglobin. Now it's not just dissolved in plasma anymore, where you've got a little car that's kind of carrying it around. So if you're looking at the arterial blood, you'd have about 1.5%-ish of oxygen that's just kind of dissolved in the plasma, but the rest of it is going to be attached to a hemoglobin molecule. Okay. So when we think about that binding to hemoglobin, your hemoglobin is going to be noted as HB, right? So that's our hemoglobin. Oxygen is O2, right? So oxygenated hemoglobin is this HbO2 notation. So we bind on oxygen to hemoglobin. We call that oxyhemoglobin. If we have hemoglobin by itself, just hanging out on its own, we call it deoxyhemoglobin, right? So D as in like without, we removed it. Okay. So we have hemoglobin, oxyhemoglobin when we have oxygen bound to it, deoxyhemoglobin when we don't have oxygen bound to it. But we can also think about how saturated hemoglobin is. Okay. So the reason we can do this is that hemoglobin is those 4 subunits, each of which can carry an oxygen molecule. Okay. So this is my fake little hemoglobin here. Right, so we've got spots for 4 oxygen molecules here. Right, you could have one right here. Right, so then we would say this is like 25% saturated. Right, if we fill up 2 out of the 4 spots, we're at 50% saturated. If we fill out 3, we're at 75% saturated. If we fill out all 4, we'd be at 100% saturated for this individual hemoglobin. Okay. So this is happening in your bloodstream. This is happening on every little hemoglobin molecule. Okay. Now, in general, if you have more oxygen coming into your blood, you're going to bind oxygen to more of those 4 sites, right? If you have less oxygen in the blood, you're going to bind fewer molecules of oxygen into those sites, right? So when we talk about the saturation of hemoglobin, we're measuring how much oxygen is bound to hemoglobin, and we have options. We don't tend to like fully empty out each and every hemoglobin molecule and then fully fill them up throughout our normal breath cycles. We'll take a look at what we do. Okay. So I was showing you what it looks like if we're filling up one individual hemoglobin molecule. Here's a slightly more realistic kind of situation. Okay. So when we think about the oxygen carrying capacity of blood, we're talking about how much oxygen can you carry to tissue? And we mentioned in our last unit some of the different types of anemia, right? So if you aren't able to carry enough oxygen to tissue, you have anemia. That could be due to a number of different issues, right? Could be red blood cell issues, could be vitamin issues, could be different things. Okay. Now, we got some new benchmark numbers here. Okay. So we are going to notice that when we're 100% saturated, right? So if we say we're 100% saturated, that means every little spot in every little hemoglobin would be completely full. So that's why you can see those little 4s there. So if you're 100% saturated, a gram of hemoglobin carries about 1.34 milliliters of O2. Normally, if you're measuring blood hemoglobin levels, it's going to be given as a number like 2 to 17 grams per deciliter. You may have done some of those calculations in phys lab, possibly in the fall, although I don't know if there have been changes. It's been a couple of years since I've been in phys lab. Okay, but regardless, there are normal levels for how much hemoglobin you should expect in the blood and how much oxygen you should expect in the blood. And these are things you could test to see whether you're anemic, right? So in general, if we're thinking about how much oxygen is going around in the blood, for about every liter of blood, we should be carrying about 200 milliliters of oxygen. Okay. Now, we're going to have a relationship between partial pressures of oxygen and how much of that oxygen makes its way onto our hemoglobin, right? So for our arterial blood, we don't get quite to 100% saturation, right? So not totally to 100. You can see here in this image, you've got one little spot missing here. Right? In arterial blood, where we have a partial pressure of 100, your hemoglobin tends to get to like 98.5% saturated. This is pretty close, right? Pretty close to 100, but not quite 100. Now, in the venous blood, with its partial pressure of 40, we don't tend to empty out our hemoglobin as much as you might expect if you hadn't read this chapter or looked at these slides yet, right? So in venous blood, so that blood that has already passed by respiring tissue, already dropped down its partial pressure to 40, you have hemoglobin saturation of about 75%. So you'll see now, it's not just one that has an extra spot for oxygen. It's like basically all of these little hemoglobins have one spot left, 3 out of 4 filled, so we're 75% saturated. Okay, so these are typical situations. Okay. So what we're looking at here is a hemoglobin oxygen dissociation curve. All right, so this is the big topic that will have a couple questions on your quiz. Won't be on this exam. Okay, but we are going to walk through it. Okay, so what we're looking at here, we're looking at how we can think about the relationship between the partial pressure of oxygen, the saturation of the hemoglobin, and also how that's going to tell us about what's happening when we get to the tissue, like how much oxygen is actually going into our muscles, going into our liver, going into whatever tissue we're talking about. Okay. So when we read this curve, we can note a couple things, right? So we know that we've got oxygen saturation here on the y-axis. What we're talking about is how many of these slots are filled with oxygen, right? So we know we typically don't go all the way down to 0. We know usually in arterial blood, we get to like 98.5%. We know that in venous blood, we're usually at like 75, okay? So those are two benchmark numbers we know about oxygen saturation. We also know some stuff about partial pressures of oxygen, right? So here are partial pressures of oxygen on the x-axis. And these are the same partial pressures we were talking about on Monday and at the beginning of today, right? So we know, because we know our oxygen cascade, what numbers we kind of expect for our oxygen in veins versus our oxygen in arteries, right? So we know in arteries, we're going to expect that partial pressure of O2 to get up to about 100, right? So 100 millimeters of mercury. We know that as we pass by respiring tissue, we're giving off oxygen, right? We are going to drop down to about 40, right? This information all links up together on this curve, on this graph, right? So what we're looking at, so there's a relationship basically based on how grabby hemoglobin feels, right? So how tightly it holds onto oxygen molecules that can be expressed in this graph form, right? That tells you, okay, so at this pressure, so a partial pressure of 0 or a partial pressure of 20 or a partial pressure of 40, how saturated do you expect the hemoglobin to be? Okay. So it's not a simple relationship, but we can notice some things, right? So one thing is that it's always going up, right? So if you have more oxygen in terms of partial pressure of oxygen in the blood, you will have a greater saturation of hemoglobin. So that's that law of mass action that sometimes comes up in your slides in the textbook, where more of something causes more of a reaction. In this case, more oxygen binding to hemoglobin, right? So as partial pressures go up, our saturation of hemoglobin goes up. Okay. But we can see that this is a little curvy. It's not quite that simple. It's not a one-to-one correspondence. What we might notice here at the bottom, right, is that around 0, we have a pretty low level of the percent oxygen saturated, and then we have a sharp kind of uptick in how fast we're saturating that hemoglobin, right? So we've got like this kind of inflection point, and the line starts almost going straight up. So this is because when we're thinking about these sites for how many oxygens can be bound into a hemoglobin, it's kind of hard to get the first oxygen in there, right? So that first one is more difficult to get in there. But once you already have one site occupied, we have this situation called positive cooperativity. So basically, once we already have a little bit of oxygen on that hemoglobin, the hemoglobin changes shape a little bit. And it's easier to now add more oxygen molecules to those other 3 sites. So that's why we see that difference in our rate of saturating. This is why we see that difference in the slope of the line here, right? Is it got easier as soon as we put in oxygen onto all our hemoglobins to put in like that second one and that third one. Okay. So when we're looking at this curve, we can now see that we have a point where our expected saturation of hemoglobin in the veins lines up with the partial pressure that we see in the veins, right? So these are both numbers that we know independently, but we can also see that they match up here on the graph, right? So under normal conditions, our venous blood, so the ones that where we've used up the oxygen, is at a partial pressure of 40, matching that 75% saturation we expect in our veins under normal conditions. So that's this first point. Right? And we can see that matching up of our other two reference numbers. So technically 98.5, right? Percent saturation of the hemoglobin in those arteries, matching up with our expected partial pressure of oxygen in those arteries, which is 100. Okay. So we can see how much saturation we have at that venous partial pressure, how much saturation we have at that arterial partial pressure. And this tells us what happened as we pass by the tissue. So like we're thinking about it in order, we're a hemoglobin molecule or a red blood cell or whatever, right? So we're coming along, our arterial blood is at a partial pressure of 100, and we have this 98.5% saturation, right? So then we hit the tissue, right? So our partial pressure of oxygen is coming to equilibrium with the partial pressure of oxygen in the tissue. And we know that we drop down to a partial pressure of 40, right? So what has happened here is we can describe this as we unloaded oxygen to the tissue, right? So for every hemoglobin molecule, right, we would have almost 4 coming along when we're at that systemic artery level with its 98.5% saturation, right? So we had 4 when we were up here. We passed the tissue and we unloaded 1 oxygen and sent it to the tissue, which is why we're now at this 75 level, right? So now we only have 3 little oxygens sitting in this car. We unloaded 1 to the tissue. Okay. The reason I'm belaboring this and trying to give you multiple ways to look at this graph and to link it up to things we've already learned is because when we think about factors that affect oxygen saturation and affect this hemoglobin oxygen dissociation curve, we're going to be thinking about the fact that certain things are going to be able to shift this curve to the right. So when I describe a right shift, I'm going to draw this same number, but like over here. So this is right. Right? That's a right shift. Or we could shift it to the left, right? So sometimes under some conditions, we're going to change how hemoglobin behaves, essentially, how much hemoglobin and oxygen like each other, their affinity for each other. So a left shift is going to drop this curve in the opposite direction, right? Okay. So when this happens, we're going to see that we now have different amounts of unloading, right? So if you'll notice here, right, with this right shift, right, you can see if we still just read, where do our partial pressures get us, right? Not changing anything about the partial pressures, right? So we're coming down in an artery at 100 millimeters of mercury is our partial pressure. Okay, we can read that about here, right? So that's our arterial blood. And then let's see when we finally cross our vein line, right? So for this vein line, for this right shift line, oh, wow, right? So we're crossing this curve at a really low percent oxygen saturation of hemoglobin, which means that to get from this artery to this vein with this right shift, we unloaded a lot of oxygen, right? So we didn't just kick 1 oxygen molecule out of the car, we kicked like 3 of them out of the car with this right shift, right? So this is why a right shift or a left shift matters. The left shift would work the opposite way, right? So for this left line, right, you can read the partial pressure of oxygen here in the arteries. Okay, when do we get to the vein? Right here. Oh, we only dropped off a tiny little bit of oxygen. We only unloaded a little bit of oxygen here with this left shift. Okay. So when we experience these right shifts or left shifts, this makes a difference for how much of that oxygen actually gets delivered to the tissue for its use. Okay. So there are a number of different factors that can affect the oxygen transport in the blood, right? And what they do is they either lower the affinity of hemoglobin for oxygen, right? So when we say a lower affinity, affinity is how much you like something. So a lower affinity basically means you're going to let go easy, right? So if you want to unload more oxygen, you want to let go of the oxygen easy, right? So that's going to be those right shifts. So we're going to have this lower affinity. We're going to let go easier, right? So we're going to have higher unloading to tissue, more oxygen available to our tissue. Okay, so we have like 4 things that can affect. Wasn't on this slide, but I think the first one your book lists is temperature. So I'm just going to mention it to you now. I think there might be a table somewhere. So in higher temperature, right, that's one of the examples of something that could cause a right shift, right? So if you have higher temperature, you have lower affinity of the hemoglobin for the oxygen, so it lets go of it easier. Let's go of extra oxygen, higher unloading to the tissue. So the opposite would happen at a lower temperature. At a low temperature, you'd have higher affinity for oxygen. So you hold on to it more tightly, right? Making it harder to unload oxygen to the tissue. I'm mentioning this because, at least in my mind, how I try to wrap my mind around the different factors that affect the affinity of hemoglobin for oxygen and all these different effects that we're walking through is I think about what would happen at a muscle when it's actively working, when it actively needs oxygen, right? Because fundamentally, you want it to release extra oxygen when it needs more oxygen. So like a muscle that's working really hard physically gets hot. So it's convenient that higher temperature causes a right shift and greater unloading to tissue. Okay. And that kind of works for these next couple effects as well. So in the Bohr effect, what the Bohr effect is it's talking about the fact that pH affects how easy it is to unload oxygen, right? So pH, a low pH is like acidity. So we're thinking, Schlater wouldn't like me to say it this way, but like thinking lactic acid buildup, right? In a actively working muscle, at least that's my little cheat sheet I have in my head here for remembering this one, right? So this lower pH, because we're actively working this muscle, we're making this tissue a little more acidic, right? That's a cue that we want more oxygen here. So conveniently, lower pH lowers the affinity for hemoglobin for oxygen. So it lets go of that oxygen easier. We increase how much oxygen gets unloaded here. So we're producing more acid, pH decrease in the tissue, right shift to that saturation curve, leading to this unloading of O2 to the tissue. Same kind of thing happening with the carbamino effect. So the carbamino effect is talking about the fact that CO2 interacts with hemoglobin. So CO2 and hemoglobin together make something called carbamino hemoglobin, which has a lower affinity for oxygen than normal hemoglobin does, right? So it doesn't hold on as tightly. So this is describing another right shift, right? So tissue that's actively making ATP is also making a bunch of carbon dioxide, right? So those carbon dioxide levels go up. That means we want more oxygen in. So conveniently, we have this right shift with this lower affinity for oxygen, meaning we have greater unloading in that tissue. The final effect that affects these hemoglobin oxygen dissociation curves. So this relationship between how much oxygen, what is the partial pressure of oxygen in the blood, and how saturated is that hemoglobin, is a molecule called 2,3-diphosphoglycerate. Okay, so 2,3-DPG or 2,3-BPG. And the difference between 2,3-diphosphoglycerate and 2,3-bisphosphoglycerate is a question for one of your chemistry professors, definitely not me. Call it either way for my purposes. Okay. So what this is a molecule that your red blood cells make when you're in a low oxygen situation. So this might be you're anemic. This might be you're working really hard, like using lots of oxygen and you've used it all up. Or this might be you're on top of a mountain, you live on top of a mountain, and the air always has like a little less oxygen than usual, right? So all of these would cause your red blood cells to make this molecule, okay? So what this molecule does is it decreases the affinity of hemoglobin for oxygen, aka this creates a right shift for that hemoglobin oxygen dissociation curve, meaning that we are better able, it's easier to unload oxygen to the tissue, let go of oxygen, which is great because we're making this under conditions of a low oxygen environment, right? So even when you're on top of a mountain, you do still want your tissue to get oxygen. So you wouldn't want this to forever make it hard to get oxygen into your muscle tissue. So it doesn't, and part of why it doesn't is that you can make this molecule. Okay. Final just a note for us. Carbon monoxide works differently. Carbon monoxide poisoning is a problem and is a problem you should be aware of. Hopefully you all have carbon monoxide detectors in your dorms and apartments. The problem with carbon monoxide isn't a shift of this dissociation curve. The problem is that carbon monoxide likes to occupy these spots. It like actually has greater affinity for hemoglobin than normal oxygen does. And if you've got carbon monoxide stuck in these slots, there's no room for oxygen. Okay, so this is how you die from carbon monoxide poisoning. Okay, on that happy note, we will end today. Happy studying over the weekend. Let me know if you have any issues, any questions. Check out those new resources. Good luck.